to our first session, which I am presenting. I'm be presenting 2 cases for you guys. And I want to introduce our panelists for that. It's Dr. Antun. She is an associate professor in hematology and medical oncology at Emory University. She's also the section co-chief of hematology and medical oncology at the Atlanta VA Medical Center and the associate program director of the Hematology and Oncology Fellowship Program. Her specialization is primarily around hematology with specific emphasis on hemostasis and thrombosis with a notable focus on thrombotic microangiopathies. Welcome, Anna.
Thank you.
Our second panelist today is Dr. Richard Burwick. Richard is a maternal fetal medicine physician with San Gabriel Valley Perinatal Medical Group in Los Angeles, California, and an associate professor in obstetrics and gynecology at Cedars-Sinai. He's OBGYN residency site director at Pomona Valley. He got his MD from UC San Francisco and MPH from epidemiology and biostatistics from UC Berkeley. He completed his OBGYN training at UCLA Harbor and a maternal fetal medicine fellowship at Brigham and Women's. He has a long-standing research interest in complement proteins and their role in preeclampsia and HELLP syndrome. He also specializes in pregnancy-associated aHUS and other TMA disorders. He has over 60 publications and has served as the PI for clinical trials evaluating complement blockade in preeclampsia and COVID-19 in pregnancy. And he's also part of the Funda-Red Materna, which is a multi-center research team in Colombia, South America, focused on studying complement biomarkers in preeclampsia. So welcome, Richard. It's great to have you both here. All right, so the first case today we have is a 25-year-old primey with singleton pregnancy who underwent labor induction at 40 weeks, delivered a female infant weighing about 3.5 kilograms, which was complicated by cleft lip and palate. She had been receiving pretty regular prenatal care, had been seeing a physician regularly, and these were her pre-delivery labs, pretty much normal. On post-delivery day 1, she was noted to have some elevated blood pressure, some drop in hemoglobin, creatinine of 1.6, some elevated AST with the other levels being normal. So I'm just going to, start off here, Richard, since this would be a patient that you would potentially be seeing at this stage. Can you just quickly run us through a broad differential when somebody presents like that on the first day after delivering a baby?
Yeah. Thank you, Anuja, and thank you, everybody, for your time. We see that this patient had a vaginal delivery. Some early signs of lab abnormalities here: acute kidney injury, the creatinine 1.6, mild LFT elevation, and then anemia, hemoglobin 8.4. I think the prior hemoglobin was 11. And the platelet count is 190. So sometimes we do see these, I would say they're catching my attention. I'm a little bit biased because I look for these patterns, just the hemoglobin dropping and the kidney injury. But we'd have a pretty broad differential. One, you mentioned the elevated blood pressure, so of course preeclampsia is always 1, 2, and 3 on our differential. She has high blood pressure, and these could be manifestations of end organ injury related to preeclampsia. It could be evolving HELLP syndrome. We'd want to see what the platelet count trend was going forward. Creatinine, sometimes we also see she had a vaginal delivery, so just obstructive labor. Was it a long second stage of pushing? Sometimes you can get like obstructive uropathy and the creatinine can go up temporarily, and then the key with that is it tends to improve pretty quickly after delivery by the next day or two. But then in combination with anemia, you also think, could there be bleeding? So the other top thing in our differential as OBGYNs is there some hemorrhage or bleeding that we're missing? More so with C-sections. So vaginal deliveries, usually the bleeding we'll be able to detect more readily. So in this case, there wasn't any description of any postpartum hemorrhage. So that 3-point hemoglobin drop raises concern. And definitely I would want to see if there's a hemolysis component to that.
Anna, anything you'd like to add to that?
No, my first thought was, probably this patient is bleeding. Hemoglobin is 8.4. The creatinine can increase temporarily. I will say, let's wait or let's recheck and see where the numbers are going.
So after day 1, all right. On post-delivery day 2, this is what happened. Her creatinine went up further, AST went up a little bit more, hemoglobins dropped more, and platelet counts dropped down further. We have an LDH and haptoglobin here. And this is often the time that, as nephrologists, we are consulted. So I want to know from you all, on the poll here, what would be your top 3 differential for a patient like this when you are consulted on?
What is this?
Right, it should give you options to put in, I think, your top 3.
Is it coming? Oh, it is not working mine.
So the fact that help is kind of it's showing up as the biggest means a lot of people have been putting in help there. It's reasonable. Atypical help, okay. Kidney failure, yes. AKI, I like that. Okay. That is impressive. So that's 88 responses. I think that we're gonna go ahead and move forward. All right. Any thoughts? Anybody wants to say anything about this? Yes, I mean.
Well, I think, first of all, that the hint that she had hypertension. You'll find in what I'm going to talk about later in transplant TMA, the onset of hypertension is a marker of endothelial injury. And I think in this case, she didn't have it before. It's 2 days later now. HELP syndrome should go away. Richard and I had this discussion 2 weeks ago. HELP should go away with delivery. There's no such thing as postpartum HELP. Okay, so I think that's a really important thing. Preeclampsia, she already delivered, so that should have been better, and she wasn't hypertensive before.
Great.
So it's certainly a marker that this could be a TMA.
Anuja, will you recap just so at home they can hear this without a mic?
Oh, yes. No, you know what? It was my fault. No, you keep sitting. I'll repeat it and then I'll go back. So that was Dr. Eileen White's mentioning that since this was postpartum day 2 and she has hypertension, that is a strong indicator that she had endothelial injury. HELP should have gone away by this time, even preeclampsia, and that we're dealing with more of a TMA. What do you have to say about that, Richard? Agree, disagree, anything else?
Yeah, I mean, we tend to agree on that. It's like Dr. White's is saying. I mean, the postpartum HELP should resolve fairly quickly, shouldn't be getting progressively worse. Obviously, the kidney injury is a big red flag. We don't see that degree of kidney injury and as rapidly as we're seeing that creatinine go up. Also, the degree of hemolysis tends to be more modest in HELP syndrome, and here from the looks of it, I know we haven't seen a smear, but the LDH level was quite high. So if it was HELP, I would expect it to get better in fairly quickly here in the next day or 2. But I am very suspicious for like an atypical HUS at this point based on that pattern, which is right now a bit more unusual for HELP syndrome.
Okay.
The other thing is that her, you want to?
Yes, I'm going to go.
Thank you. The other thing that's important is that her transaminases, it's only the AST that's elevated. Her ALT is normal. So the liver is not involved. This is from hemolysis. This is red cell related and platelet related.
Yeah, and we haven't seen the bilirubin, so fractionated bilirubin test would be important to see, like you said. And even, some people have shown that you can get a little bit of the AST release from red blood cells. That's one pattern that I look at is the ratio, and some people have looked at that ratio of LDH to AST. I think it was over 10 to 1 or 20 to 1 almost here.
So LDH to AST? Yeah, 1950 over 13.
Yeah, so because some people say, well, the LDH, and we hear this a lot from OBGYNs, that this is just tissue injury, ischemia, and the LDH is nonspecific, and we agree. But here, actually, we have haptoglobin, so we know there's at least a red cell homolysis, and hopefully we'll have a smear soon to know, is it microangiopathic? We suspect it's microangiopathic based on the clinical presentation, but exactly. So having the haptoglobin to confirm you have hemolysis, and then the hemolysis out of proportion to liver injury tells you that, kind of what's driving the pathophysiology is going to be a TMA more so than if there were like a acute fatty liver, it would be more like the liver dysfunction that would be driving the picture rather than the hemolysis.
So you think help may be less, but you still can't rule out TTP yet, right? Anna,
Yeah.
what do you think?
So, but I want to ask Richard, so how long, because we don't see, they don't call hematology in the first,
Couple
in the
days.
first day, but, so how long you're going to wait to call us if it gets worse?
Yeah, I mean, we should be calling you now, but you're right, a lot of OBGYNs will say this is help, I've seen a lot of help, we'll give it a day or two, it's gonna get better, and then you're right, they'll wait another 2 days and the patient's getting worse, and then they call hematology. I would at least send the ADAM TS13 here for sure, because there's TMA, and I think that's one thing I push for with OBGYN colleagues in maternal fetal medicine is send the ADAM TS13, because most of us don't have a rapid test, most of us, it's taking 5 to 7 days. And so I want to get it going. I think definitely this would be someone I would want to send the ADAM TS13. I'd be calling hematology and nephrology to get, but you're right, not everybody does. I think there's definitely a delay in many
So
cases.
with these labs, I would like to know the retic count.
Correct.
I would like to see the smear. You mentioned, but because you mentioned the Adams TS13, although the creatinine is a little higher than we will see in TTP, but it can happen.
it can
This is
happen.
pregnancy, postpartum. And then I would like to see the total BILI and direct BILI to go through all the differential diagnoses. That my concern, if I see those labs and ask the retic count and the retic count is high, is first I will want to treat this patient as a TTP until we have the Adams TS13 and or clarify that it's TTP, or we are thinking in another TMA.
Sure. So the retic was high, but the peripheral smear only showed 1 to 2 schistocytes. Gloria, 1 second. Gloria, you had a question?
Oh.
Just turn it, yeah. If you pull up with the button.
I think it's already on. I was just curious, maybe it was stated and I missed it. How many weeks did she deliver at?
40.
40, yeah.
Oh, so it was a full
She was
term.
induced at 40, yeah. Yeah, Janavet, go ahead.
I'm sorry for the naive questions, but if postpartum preeclampsia do exist, it has to start somewhere. So there has to be a low activity, worsening of activity, and then gradual improvement. So if postpartum preeclampsia exists, then we should allow the lab to get worse, right? Or maybe it's that postpartum preeclampsia don't exist, and this also, go along with the whole spectrum of severe preeclampsia and HELP. So just to kind of like expand on that point, like a worsening lab, can it still be preeclampsia?
So you're wondering at what point postpartum would you say that this is not preeclampsia? Is that what you're asking, Janavet?
Yes, because if there are worsening lab and as the
And we're
point-
still thinking it's a preeclampsia. What do you think, Richard?
Yeah, and we do see a lot of postpartum hypertension. I think with the preeclampsia, the endothelial dysfunction, obviously we have that in preeclampsia as well. That doesn't get better, right away. And we do see persistent hypertension. I think the hematologic parameters and the kidney injury, that's the question whether that TMA should persist. And my argument is that it shouldn't persist because the treatment for preeclampsia is going to be delivery. And the endothelial dysfunction, it takes time to heal. So I think the blood pressure sometimes is what lingers. But the other parameters, in my experience, should improve, fairly quickly.
So you should expect the creatinine to turn around and hemoglobin. So would you say 48 to 72 hours, or is that?
Yeah. And I mean, the only time where it might linger a little bit more would be acute tubular necrosis. And, a lot of times when we look at the differential HUS versus TTP or versus HELP, but the thing that gets confused the most is acute tubular necrosis. And, that's a kind of a broad term. So I think, but here, I'm not really thinking, there could be eventually some tubular necrosis that occurs, but we wouldn't have that degree of hemolysis. So I think that the combination of the two in particular is really suggestive.
Kenor?
Hey, so great discussion. Now that we have an FDA-approved test for preeclampsia, would this be the perfect patient where we would send this?
The SFLT one? Dr.
Yeah, so you're talking about the recent US FDA approval to use SFLT PLGF as a biomarker for preeclampsia for the angiogenic imbalance. The hard part, we don't know what those levels do in pregnancy TMA, but you're right, they would lean you towards preeclampsia. Also, they should improve quickly. So most of the data on SFLT and placental growth factor is rapid improvement following delivery. And so I would say if those improve and the patient's getting worse, then that would push you the other way. We wouldn't, they're not approved for postpartum testing, so it would be a little bit of not as much data. But I would say if you really were trying to make a quick decision and this test is available, a ratio that's basically going down below preeclampsia levels.
That's 40? Is that 40
below,
or 80?
they're going to
85?
use, well, the one that was approved was the one by Thermo Fisher, and they used a cutoff of 40.
40.
It's a little bit different than the Roche assay, which is used in other countries. But yeah, so they have basically below 40 would be considered negative.
And that's,
Yeah.
how soon do we get that back? I mean, I don't know if we even have that available right now.
Right now, I think Roche, I know, would like to get their test approved because I think more hospitals have the Roche machines. They don't have the Thermo Fisher. If you do have the Thermo Fisher machines, you could do it in-house. The test is relatively cheap. I think it's been quoted at like $30, $40. But it's probably would have to be a send-out if you didn't have the equipment
To do it
to
in-house.
do it.
Okay. All right, let's see what happened here. So we talked about additional testing. Several of you mentioned Adam TS13. Any other testing that you would do? Yes, Gloria?
I think lower on the differential, but certainly a consideration is CAPS. So I would send antiphospholipid testing and a DRVVT or whatever the lab is using for the presence of a lupus anticoagulant that could help potentially elucidate things down the road, although it doesn't necessarily, and it may alter management, but perhaps not pathobiology might be quite similar.
Yeah, that's a really, really good point. That was actually what I wanted to ask, that if and when would you do antiphospholipid testing in these patients? Do you do it routinely on all patients, or there are certain red flags that point you towards doing it?
So in general, we don't order up front with a patient with hemolysis and
Okay.
thrombocytopenia, but those patients in general, they have some history of autoimmune disease, or they have the diagnosis of lupus that you will give you like a red flag to order it, but it's a very good differential diagnosis.
Yeah, I agree with that too, because we have to be cautious that they can be falsely elevated. I do send them, tend to send them, but it could potentially lead you in the wrong direction, because it can be falsely elevated in pregnancy, and then it may alter your treatment course and perhaps move you away from complement-mediated TMA when it actually was a complement-mediated TMA. So it's always, just a little caution and looking at the big picture. We want to, of course, open the differential diagnosis. I think the clinical history, right, was there any reason to suspect, antiphospholipid syndrome beforehand is also helpful.
Eileen, you were going to say something?
The other important thing to realize is that CAPS, catastrophic antiphospholipid, is characterized, that CAPS, catastrophic antiphospholipid, is characterized by rapid drop in platelet count. It looks just like AHU.
And the thrombosis.
And we have 6 cases where the patients had underlying complement mutations and respond to complement inhibition. So complement's really driving that particular dysfunction.
Yeah, that was my thought too, because we do use complement blockade for CAP. So would it really alter your management if you did diagnose it mistakenly or not? That definitely
Well, you
brings.
need to repeat the parameters more than once. That's part of the problem with antiphospholipid syndrome.
Right.
You have to repeat it 12 weeks apart to make sure it wasn't just temporary.
Right.
Yeah, and we don't have the 12 weeks.
Right.
Right.
You don't want to wait 12 weeks. But I think the important thing is it's a good thought in this setting. And the characteristics present just like atypical hemolytic uremic syndrome.
Sure.
Yeah.
And one other thought was, and this is a question that comes up, what about B12 deficiency? And how often do you see that as a mimicker for TMA? How often does that get diagnosed for the first time in a pregnant woman? And what would you be testing, just a normal B12 level or what?
So, few points. In this case, so in a patient that has B12 deficiency, that doesn't happen overnight. So, she has normal hemoglobin, normal counts before delivery. I will not think upfront, oh, this is B12 deficiency. There is cases of pseudo TMA on B12 deficiency. The cases has severe B12 deficiency with that present in a similar way that TMA, because it's DNA synthesis in the bone marrow and then doesn't produce the cells, so you have pancytopenia and you can have hemolysis. But what is not going to have is high retic count in in the TMA, the retic count is going to be low because the bone marrow is not producing cells. So this is the point to distinguish how is TMA from pseudo TMA for severe B12 deficiency.
Excellent.
I will not think when I look at the labs and I ask you for the retic count, the retic count is high. He had other cells that my white blood cells were normal, so I will
You
be
will not be
less
worried
likely
about that.
thinking.
Okay.
Was the MCV high?
No,
92, no.
no, it wasn't.
So that would kind of dissuade you away.
Yeah, but
Yeah. We've had 2 cases at the county hospital who presented with neurologic dysfunction and what looked like TMA on the smear and was in fact B12 deficiency.
Which is why I bring this up. I think we had a well-known case that was missed at one point, right?
Yeah, we had a case, I think you're right, looking at how they came in, we had a patient that I think 20 weeks, so one was already a little early, but she came in and was presumed HELP syndrome because the LDH can go fairly high, so that, and there can be, right, schistocytes, low haptoglobin as the red cells turn over. So that can look a lot like HELP syndrome. Usually the liver tests are normal. The case that we had, that was actually the case. The doctors called it HELP syndrome, but one red flag was that the liver enzymes were normal.
Yeah.
But she came in with elevated LDH, low platelets. So you're right, versus this case where there was proven normal labs to begin with. But yeah, maybe if you look at some cases, like what were their labs when they came in,
Would
that's
be
where you might go back and
pointed towards
consider it.
Sure.
There were 2 cases published in Blood, one, both of them from Brazil, 2 kids who had cobalamin C deficiency, and they had already been started on complement inhibition and weren't responding.
And that's another
Well,
red flag.
there's a big differential in cost
Yes.
for a country where you have to petition to get the drug.
True, true. So what would you do next in this case? What would be the first next thing you would want to do in this patient? You can just raise your hand, answer anything. Anybody? What do you think, Anna?
I will start plasma exchange. I am sure this patient, they come on the weekend or Fridays, always these patients
That is
show up.
exactly what happened. So this is copy pasted. I did not make this up. This is copy pasted from the patient chart. This is what hematology recommended. These were recommendations from hematology. This is what the OBGYN wrote. Discussed with heme in case the patient needs pheresis. Given the logistics, it's a Friday evening. And this is the absolute truth. I don't know why this has to happen. They have concern for TTP. We don't have an ADAM-TS13 testing until tomorrow. We can't distinguish TTP from HELP. And in the setting of gestational hypertension, concern for HELP is still there. And then right after that, the next note is from the maternal fetal medicine. It says she was hypertensive during her postpartum course. Labs are obtained concerning for HELP, which is, of course, the most common TMA. But the degree of renal insufficiency is concerning, and AHAS should be considered. Hematology is concerned for TTP. I'm recommending a renal consult as her AKI is concerning, and discussed use of anti-C5 should be considered. And like I said, 2 slightly different approaches from the same patient, 2 notes within the same day. And so here we have the ADAM-TS13 has been sent, it's pending, Plex is started, as Anna mentioned. She's received it already for 3 days, prednisone started. And this is day 5, and her creatinine's up to 4. Platelet counts hanging around 33. LDH up from 1950 to 2230. Hapto is low. ASD is slightly higher. MCV, as you asked Eileen, is 92. INR is 1.1. And then here is what I want you to tell me. How long does it take for ADAMTS13 results at your institution? Oh, sorry. I keep forgetting. I have to activate it, don't I? Sorry. Go ahead. I'm really curious to know the less than 24 hours. Which are those institutions where have less than 24 hours? Anybody in the live audience here, or is it coming from the virtual audience?
Wow.
It depends. If it's a weekend, I can't say less than 24 hours. But if it's a weekday,
And you're at Johns Hopkins, right, Gloria? Okay.
if it's within, sent in the morning, then yeah.
You get it back within 24 hours. That's impressive. We didn't have too many responses here.
In research, we have a result within 30 or 60 minutes.
Wow.
You do that in-house, of course?
Yeah,
And
we implemented a rapid ADAMTS13 testing a couple of months ago, and it worked very well.
that's amazing. And you, Morel, can you tell you're from Belgium, right?
Yeah, from,
Yes, yeah.
Yeah, so thank you very much. So that's very important, of course, to have ADAMTS13 activity. In such a case, or in any patients with suspected TMA, this will impact greatly the management of those patients. And so, yes, with this technique, we have a result within 1 hour. And we also now have the opportunity to test for the Shiga toxin in all patients with TMA. And to get the result within 1 hour. So basically,
1 hour in
one hour,
Shiga
1 hour for both Shiga toxin and ADAMTS13 activity. Yes.
And
So-
you developed this testing in-house, you said?
yeah, actually, for the Shiga toxins is a PCR multiplex, which is commercially available.
Yeah.
So we test like I think 22 genes,
Yeah.
including the Shiga toxin genes, and we are validating the technique against the conventional PCR, and it works very well.
Excellent, excellent.
How long take the inhibitor to come back?
The inhibitors might take time, yeah.
Yeah, it takes a bit longer, but actually, in those patients, once we have the results of the ADAMTS13 activity, it's below 10%.
And then you at least
yeah.
helps
And
your management.
in such a patient, if you suspect TTP, we would discuss with our hematologist, and we would even discuss adding on top of PEX the caplacizumab, 1 dose of caplacizumab, just to prevent thrombosis or so the
Does that get pheresed or no?
sorry.
You do pheresis and then you add the capla?
Yeah,
No?
on parallel. Yeah. We start the PEX, and we give 1 dose of caplacizumab.
But does it get pheresed out? Does it get pheresed, or if you have to repeat pheresis, what is the situation?
We discussed this with the hematologist. I don't know exactly.
You don't know, okay.
So,
Generally,
no, go ahead.
generally, if you're giving it upfront before pheresis, you can give an IV dose before the pheresis, and then after the pheresis, you give a sub-Q dose, and then on subsequent days, you follow with sub-Q doses after the pheresis session.
So IV first, pheresis, and then you guys do a sub-Q
That's the way.
capla.
Correct. This is the way.
That, yeah? Okay, all right. Well, I just want, yep.
Another thing you might think about, so both the French TMA registry and the Ohio State data suggest that you can really use the platelet count and the creatinine to help distinguish which disease this is. The fact that the creatinine's over 2, the platelets were 42,000, that goes for AHUS.
You're talking about the French scoring system,
Right.
right, Eileen? Yeah,
So their registry,
yeah.
this was from their registry. So I think that that's a clue as to what's happening, and you can use that. The only time you may get a little bit confused, we had a patient who was a child, a 3-year-old, that they called about, who the creatinine was 1.5, which didn't seem so high to me, but I'm an adult hematologist. But to a pediatrician, that's really bad.
Really high, yeah.
And so the resident pointed that out to me, And so it was a significant elevation in creatinine, and we just start the patient straight away.
Yeah, no, I think that's a really good point to remember for, places where we don't have that availability. I just wanted to put in a plug-in for, I know in a program that USTMA has started, Fast for TMA, they're offering a free testing at home and in hospital, and the turnaround is anywhere from 6 to 24 hours. There's a lot more information on the website if you want, but we've used it. I've used it on 2 patients, and it's worked really well. The company will send the courier to the place wherever you are and get the testing drawn. So definitely something the consortium is proud of having started. All right, so next thing I want to ask you is, you are familiar with the plasmic score. In the absence of a readily available ADAM-TS13 testing, could you use plasmic score? And I will go ahead and start this, but then for those of you, just to remind you, do you remember, it's the plasmic scoring system that takes into account platelet count, hemolysis parameters, and if you don't use it, you can just go ahead and answer no, but if you do use it, I want to know whether you would use something like this in a pregnant patient. And does the other mean you never used it or you don't know the score? Not sure what the other refers to, but.
I reply the other because it can be indicative, but we all have stories where with patients with HUS, with very low platelet counts, and also patients with TTP, with acute kidney injury, which is quite common actually.
Yep.
Both in our experience and in also the French registry, I think that 50 to 60% of patients with TTP have acute kidney injury. So.
And you're saying that in general, Morel, or are you talking about just pregnancy?
In general.
In general, yeah. Okay. All right, I'm going to move forward. So actually, I want to know, Anna, what do you think? Do you use it, not use it, and what is your take on plasmic score?
I think for hematologists, we don't use it, but we recommend it. What it's going to give us is...
That's a great one.
Well, let me explain. So what it gives you is the probability of low ADAMS-TS13. That's it. So for the plasmic score, so if you are not sure, you can do it and give you the low probability. But it has other things. We have TTP, patients with TTP with high creatinines. We have, so it's a help. What I will not recommend it totally is to use it in pregnancy because it has not validated for pregnant patients.
Yeah, that's exactly what I wanted to hear, is that the studies did not include pregnant patients, and so that is the question here, that do we use it, can we use it or not? And so, just for kickers, the patient's plasma score was 4, if somebody wants to know.
And then if you have a high suspicion that could be TTP, I will treat as a TTP. Remember, the mortality without treatment is 90%. I know that if it's a typical HUS, you are delaying a little because you are treating as a TTP, but you delay the renal injury, but not
the
high
mortality.
mortality. So
Yep.
if I have a doubt, I will treat as a TTP until I have the ADAMS-TS13. Now, you have in less than 24 hours, so you will decide right away, but for us, that we don't have it yet.
So the bottom line is not very reliable in pregnant patients.
It's not validated
Okay.
in pregnancy.
All right, good to know. All right, so the next study here was actually led by Richard, and this was looking at, the plasmic score, we're talking about something that'll help us differentiate TTP from others. This was a really interesting study, and I'm going to let Richard talk about it a little bit more now or later on, but this was trying to differentiate HELP from atypical HUS. And what he showed with this cohort was that if you have a creatinine of more than 1.9 or an LDH of more than 1832, or a combination of an creatinine more than 1.9 with an LDH of more than 600, then it was more than 95% specific for AHAS. And just for perspective, this patient's creatinine was 4 and the LDH was 2250. Richard, thoughts, ideas about this study?
Yeah, exactly. So we kind of designed that, a little bit with that in mind, the TTP versus atypical HUS and how the plasmic score doesn't take into account HELP. Well, HELP tracks with TTP, so HELP usually has a plasmic score above 5 or 6 in most cases because it doesn't really apply in that situation, right? But we saw, clinically that postpartum atypical HUS, the degree of renal failure was much more severe and also the degree of hemolysis. But we took patients with, these are postpartum cases predominantly, and they were all postpartum cases, and looked at just basic lab parameters versus postpartum atypical HUS. And definitely like hemoglobin platelet count are lower in atypical HUS versus HELP, but they also go, quite low in HELP syndrome. So even though there's a little bit of a difference, they didn't really differentiate as well. Liver enzymes, people might think, well, liver enzymes would push you towards HELP syndrome. They didn't really differentiate. When you look at the case reports of postpartum atypical HUS, they tend to have elevated liver enzymes, and that's true in many of the cases that I've had as well. So we found liver enzymes didn't really discriminate one way or the other. And then it really came down to hemolysis and kidney injury. And with HELP, what we saw, some people say HELP is defined LDH over 600, but most cases of HELP have LDH in the 300, 400, 500. They don't even get to 600 most of the time. And in the creatinine, we consider a severe creatinine elevation in pregnancy over 1.1. And so we might see something like the 1.5, 1.6, but we don't see it go up above 2 very often. And so even that alone, obviously if you're at 72 hours and you see a creatinine above 2, there should be a test for hemolysis. And that's, one why we had creatinine alone was because many OBGYNs aren't testing for hemolysis. And some people are surprised that many hospitals around the country, there's no test for hemolysis. And so they should at least be, okay, you have acute kidney injury, let's test for hemolysis.
You're talking about LDH?
Just LDH.
Simple LDH, yeah.
Even
Okay.
as a first step.
First step, yeah.
And this is because the American College of OBGYN doesn't recommend testing for hemolysis in patients with preeclampsia. And most OBGYNs follow those guidelines, so they just don't check it. But it's very useful, you're right. I mean, you still have to take additional steps, do the haptoglobin, do your retic count, peripheral smear. But if you have the combination of hemolysis and kidney injury, like we said, 95% specific for atypical HUS as opposed to HELP syndrome. And so we found that, very useful clinically.
Sure. Somebody in the back had a question?
Sorry, I didn't get to read the paper. How did you confirm the diagnosis of atypical HUS in your cohort?
So the atypical HUS cases were from the literature. Because I think we had about 40, 45 cases that we gathered. So actually, if anything, they were a little bit more severe because these were case reports. I think you could even maybe lower the level a little bit. But so there is some publication bias. The HELP syndrome cases we were able to take from our own institution. But when we apply this to our patient management, we've had about 10, 12 patients that we treated more or less. They fit into that algorithm perfectly in most cases and respond very well to the complement inhibition.
All right, so this patient's ADAM-TS13 came back at 69%. The C3, C4 came back, C3 low at 62, C4 at 25. Question for the audience is, do you see utility for low C3 in a patient like this with a normal C4? How often would you order something like this in your pregnant patient, and does this tip you one way or the other? Anybody? Anna, I'll let you handle that. What do you think? Because we know there is some complement activation with TTP, but here we're seeing an isolated low C3.
Low C3 and normal C4, what it's telling me is like an activation of the alternative pathway. It's not telling me anything else. It's not telling me that this is a typical HUS or not. And it could be TTP and was activation of the complement pathway. And so I don't order it, and
Okay.
this is what those numbers are telling me.
That's perfectly reasonable.
Can I comment about Adams TS13?
Yes,
So
I
it's
do
only-
actually have that question coming up for you.
So Adams TS13 is normal levels in pregnancy is between 20 and 40. It takes 3-4 days to start slowly increasing and 7 to 10 days to normalize.
So here, yeah, this obviously came back after 4 or 5 days, so you agreed
Yeah.
that this was fine.
Yeah, that is fine.
But my question for Adam TS13 was that, 20 to 40 in pregnancy, would you typically want to repeat these levels a few weeks down the lane to see that they have normalized? And there is, because, there's some data to show that if patients continue to have intermediate levels, there is long-term risk of cognitive dysfunction and things like that. So do you routinely retest these patients?
I do in my patients, but
Okay.
we don't see them so often.
They don't come back to
Not all
you?
those patients come back to us.
Okay. All right, so let's see what happens. So Plex was stopped after the Adam TS13 results came back, and then at day 7, the plan was to start C5. She was given the drug, the prophylaxis. Creatinine at this point is 11. She required dialysis because her urine output had dropped. She had developed acidosis. Platelet count was lingering in the 30 to 40 range. AST kind of peaked around 188 and improved. She goes home after 2 weeks. She had gotten 2 doses of anti-C5 in the hospital. She went home on dialysis. When she went out 2 weeks after discharge, and this is 4 weeks after delivering the baby, she's still on dialysis. Her LDH has improved, her haptoglobin has normalized, the platelet count has normalized, and urine output's improved. She came off dialysis about 2 months later. Creatinine's at 1.8, and it took 6 months for it to normalize to 1. The question is, would you continue eculizumab in this patient? And let's see if we have a poll. All right, what would you do?
How many months?
6 months.
Okay, so the need more information, what are you looking for? Anybody? Yes, Kenar.
I think based on the trials we have seen on atypical HUS from France, this would be a place where genetic testing would be useful. And if they have some sort of genetic mutation, especially complement factor H, then I would continue lifelong for now. And this patient might have a feeling. But
So more information includes genetic testing. For those who don't want to continue, is that because the creatinine's improved? Any other thoughts? Yes.
So while I agree, I'd certainly like to see genetic testing. I don't think that would per se, if she's now improved to a normal baseline creatinine, assuming that all of her hematologic parameters have normalized, and that she's no longer hypertensive, so I would also want to know that she's off all antihypertensive medicines. I still think even with the presence of a mutation, it's reasonable to closely monitor off a complement inhibitor. The other consideration we sometimes look at is CRP. So we'll test that sometimes in the acute episode and also—
The C-reactive protein?
Yes.
Okay.
In the acute episode, and also kind of in remission towards stopping, and monitor that, and have found that a normalization of the CRP may also—
I had not heard of that. That's an interesting information. Anybody else looking at CRP? That's a really interesting point. So, and would there be a duration for which you would continue this, Gloria? Like for 6 months, 4 months, or you just stop at this point now that she's better?
Assuming that everything
Yeah,
has
assuming, yeah.
otherwise normalized, there's not. I think it's reasonable to stop
Okay.
at 6 months, knowing that she had this very distinct trigger of
Right.
pregnancy.
Okay.
There's
Morel?
a question in the chat.
Yes.
Can you elaborate on the comment that ADAM-TS13 activity is 20 to 40% in pregnancy?
Yeah, so during pregnancy, and if we have time, we have slides, but during pregnancy—
If you're covering it in your slide, we can wait for that, because are you covering that in your slide, Anna?
Yeah, it is
Okay,
in-
can you
in
let
one of
them
the
know in the chat that, we'll cover that during discussion for sure. Morel, you had something to say.
Yeah, just a comment about the duration of eculizumab in
Yeah.
patients with atypical HUS in the setting of pregnancy-associated HUS. Actually, we don't know the exact answer. How long should those patients be treated? We don't know. Of course, there is the information from the French registry showing that patients with high-risk mutations or high-risk variants such as CFH are at high risk for relapse after discontinuation of eculizumab, but we don't know. So our national policy in Belgium is to treat patients with atypical HUS in the setting of pregnancy or not for 6 months, 3 to 6 months, and then to stop. And then we discuss with the patient, based on genetic testing, the risk of relapse, but we usually stop the treatment. We stop and we follow closely the patient, and we are ready to restart in case of relapse.
But by that time, if you're giving it for 6 months, by that time your genetic testing results are in your hand, right?
Yeah, we get the results within 3 to 4 months.
So you'll base it on that?
No, we don't decide based on the
Oh,
results.
you stop it regardless, you discuss the risk of relapse with them.
Yeah, we stop for every patient with atypical HUS, first episode of primary atypical HUS, we stop after 3 to 6 months.
Okay.
And we discuss the risk of relapse based on the results.
On the testing. And what about, is this the same policy for transplant as well, or just native kidney?
So it depends. So if this is the first episode of TMA of HUS, this is our policy. For prophylaxis after transplantation, we have 0 to 6 months prophylactic eculizumab treatment based on the risk, the genetic risk. And in case of relapse on a transplant, then on a case-by-case basis, we discuss the duration. But of course, if a patient has had kidney failure due to atypical HUS, then a transplant and relapse on a transplant, we continue for a long-term duration.
So her genetic testing came back. She had a variant of uncertain significance in factor H. And it was called a VUS. Richard, can I pick on you here? I was waiting for you to say something. So question is, what do you think, why do you think they call this a VUS even though this was a splice variant? Do you think that's because it was intronic? Any thoughts on this?
Yeah, so
I can read it out to you. Do you want me to read it?
Yeah.
Yeah, so basically they're calling this, it's a variant that incorporates a conserved nucleotide position in intron 20 in CCP 18, which is essential for proper structural folding and protein function. It occurs at a canonical splice site towards the 3' end of the gene, and in silico tools that evaluate the effect of splicing variants predict that the variant alters the wild type acceptor site and results in a most probable alteration of splicing, although the precise biological impact is unknown, and it has not been reported in any population databases, including NOMAD, has not been reported in context of AHAS, and according to the ACG-MG guidelines, it's a VUS. I was surprised to see that a splice variant was called a VUS, and I just wanted to see what your thoughts are.
So each of the SCR, each exon in factor H encodes one of the SCRs. And so, and they're all in frame. And so that means that factor H will be made, and it will still have the last two SCRs, 19 and 20.
Mm-hmm.
And so,
so if it's in frame, and even though it's a splice, and it's not causing a protein that is smaller, is that why, maybe?
No, it depends where in frame it is. And so if it's a splice variant in intron 20, then exon 19 is going to be missed, and exon 19 encodes SCR 16 or 17, I think.
I don't know how you keep
And
that
so,
in your head.
and so that's,
I have to open my book every single time.
And so you still have the last two SCRs of the protein, and the last two SCRs of the protein are most important for factor H function and prevention of control of disease on the cell surface, control of complement activation on the cell surface. So I think the only way to know
is to make it.
Is to do some in vitro studies.
Correct. All right. So if you have a variant of uncertain significance, the question to the audience is, what is, of course, as Richard mentioned, there are multiple ways to handle a VUS, but what is the first simple thing that you could do to know whether this is a problematic variant or not, I want faculty, junior faculty and trainees to maybe attempt this question. If you get it right, you have a champagne or a chocolate box for you there. What is the first simple test you could do for a variant of uncertain significance? Just Janavel, I do expect you to answer that correctly. By the way, he's on our ClinGen gene curation panel, so I'm expecting him to answer this.
So if I am in the bias that I want to assign this as a pathogenic variant, I wish that this splice created an NMD to that mRNA. So I would love to see a lower CFH level when the activities is normal, because if there is a deletion in one gene, I would expect that maybe the baseline level is low.
So the test you would order is a factor H level?
Yes, and by this time, whether it is low like this, I'm not sure if ordering it during the time the genetic test was done, that would be when the disease activity is pretty activated. So the complement factor H will be consumed. So I'm not sure if sending the functional test then or when it is quiet, would it make a difference?
So the level is different from the functional testing, right? So a test, you're just checking it, as long as it's not done right after pheresis, just checking a level of the protein is important to see. If it's low level, you've kind of really determined that this is problematic, and that's kind of what we're looking for. So for this patient, I would give him whatever he wishes. So I think you were fairly close, yes. So functional testing is a little bit different, but antigenic, serum antigenic level, I think is definitely a test that is available. Wow. And and so a simple test, widely available, you can send it out, and if you get a low level, the variant of uncertain significance ends up, you know that this is a pathogenic factor H. So the questions here are, what do you think is the risk of recurrence in this patient with a pathogenic factor H mutation?
Can I just say one thing, that I think it is really important to do mutation analysis in this patient. One, if you believe the Hopkins data that, yes, if she has an underlying mutation, then she has a high risk of recurrence. But regardless of that, she's probably going to want to have another baby.
Yep.
And then what are you going to do?
Yep, and that exactly my question is, what are we going to do for future pregnancies? So do we all agree that the risk of recurrence is high? Yes, with that mutation. Can you predict what triggers might be needed? This was a pregnancy in a patient who had lower factor H levels. She needed a pregnancy for her to get a TMA, which was also an interesting fact, because sometimes you don't need a big trigger like pregnancy for a pathogenic mutation. Is there any way you could predict that is it going to happen in a repeat pregnancy, or it can happen anytime with any kind of trigger? Any thoughts? Yes, Murda. Do we have a mic for him?
So thank you very much. The risk of recurrence based on the French registry would be 70%, if I remember well. And the risk of recurrence during a future pregnancy, if I remember well, the data from a JSN paper some years ago is around 20 to 30%, and is independent from the genetic testing. So there is no risk stratification based on the risk of relapse during a future pregnancy as compared to the risk of recurrence after transplantation.
So there's no way to say, is that what you're saying?
Yep.
Yeah, yep. Okay. And, well, I guess if you keep this patient on something forever, I think we would all agree to switch her on something long-acting. How would you counsel her for future pregnancies? I have just a couple of cents on there, Richard.
Yeah, I agree. One, you're right, the increased risk of recurrence, if it was provoked by pregnancy, obviously we would be concerned for increased risk. I think, like you said, around 30, 40%. And if there's a pathogenic mutation, maybe even higher, but we don't have all the data on that for pregnancy. Also, high risk for pregnancy complications. So patients with either TTP or atypical HUS, very high rate of preterm birth, preeclampsia, placental abruption. So we see that they tend to have other pregnancy complications as well. She responded well to treatment, so I would definitely recommend going back on complement inhibition with the start of pregnancy. I think in this case, if she did have a pathogenic mutation, I'd rather start it up front, and I think there's good safety data for that. And then, of course, the other option would be surrogacy. I know many of my patients have chosen surrogacy just because this case, I think, was relatively straightforward, but many have really complex, prolonged cases in the ICU after delivery, and often are hesitant to carry another pregnancy. But I think if we treat sooner, if we recognize disease and treat sooner, their recovery is quicker. I think we may have more patients that seek out additional pregnancies, especially in the age with treatment availability.
Awesome. All right. Any other thoughts or questions before I move on to case 2? Yes, Gargi. She's all the way in the back.
Hi, I have a question. What is the role of a kidney biopsy in this patient? In the earlier scenario, when we are still not sure of the diagnosis, but there's a high clinical suspicion, before you do plex or while the patient is getting plex?
Well, if the clinical suspicion is high and the platelet count was that low, I think you're risking the chances of, you're taking a bigger risk than anything. So I personally would not, with that level of LDH, HAP2, her creatinine dysfunction and a platelet count of 30,000.
Are you going to do a bone marrow?
Yes, Carla.
I think I would also add that though I happen to be a nephrologist, so very pro-biopsy, I think the dilemma you'll face is that a TMA looks like a TMA looks like a TMA. So regardless of what you see on the biopsy, it's not going to help with your differential. So you're potentially subjecting her to additional risk without a really, treatment-defining event, if you will. So I might avoid that in her.
Excellent.
But I will add, because I think it's an important point, I know we're discussing, without a lot of data, whether we should continue, not continue, when we should restart, et cetera. If this was a heavily scarred biopsy because she hit a creatinine of 4 something, I would be a lot more likely to start complement blockade early, prophylactically, keep it on longer, et cetera, et cetera. Again, recognizing I don't have data for that, but I'm really interested in preserving the kidney and not having another AKI or ischemic event.
I agree. The patient is currently on ECU, and we've left her on it. So for now, we have. All right, I'm going to move on to case 2. We have taken a lot of time for case 1, which is great, but that's going to help us with the discussion for case 2. I'm going to go through quickly because there are some of the common themes, but I want to kind of highlight the differences. So this was a 27-year-old primary singleton pregnancy, had a C-section because she had a breech presentation and preeclampsia. She had COVID a week prior to a C-section, delivers a male kid, 2.5, 2.6 kilos. She had also been receiving prenatal care, completely normal labs. Post-op day 1, she has decreased urine output, shortness of breath. Initially thought that this was postpartum cardiomyopathy. Cardiology was consulted, echo was normal. They thought, well, her heart was fine. This was maybe related to the physiological changes, and she had been getting fluids. And her creatinine now is 2.8. Prior, she was 0.8. Her hemoglobin platelet, as you see, her LDH and HAP2 are, slightly up, and HAP2 is down. The question is, and then this is post-op day 2, her creatinine's bumped up to 4. This is her C3, C4, ADAM-TS 13 is pending. Question is slightly different from the first case where it took a little while for the kidney function to get to this point. This is day 2 and her creatinine's at 4. Would you do anything differently compared to case 1? Adam?
So now the platelets are a little higher. I will not start plasma exchange right away.
Okay.
No. With a creatinine of 4, I will not think more like first option to be TTP. I mean, it's fine that they order the ADAM-TS 13 and probably it's easy for differential diagnosis, but I will not.
Right. So actually for this patient, anti-C5 therapy was started on day 2 right away. She did not get pheresis. And so creatinine did continue to rise. It peaked at 6.5, but that was 3 days after starting and then started recovering. And she recovered within 2 weeks. She was down to 1 milligrams per deciliter. Did not require dialysis. Heme parameters were better. ADAM-TS 13 came back at 31%. How long would you continue ECU in a patient like this? And I don't have a polling question, so just kind of raise your hands, tell me what you think, or do you want more information here? Yes, Kenar.
I would have biopsy this patient.
Okay.
Because this is the one patient where you have room, the platelets are 87. This could be ATN, I don't know.
Yep.
I mean, the creatinine would recover very quickly. I don't know if influzumab really did anything. It might have. But this is the one I would biopsy to find out if that's happened, and then decide on continuation or not. This one I would not continue as much as you did with the first one.
Yeah, so not much longer, but so when would you biopsy now? Like 2 weeks later, creatinine's down to 1?
Not now, I wish.
We would have done it earlier. So, yeah, so maybe in that 2-week time frame when we were waiting. Okay, all right. Well, she did not get a biopsy. She was getting the drug, and her genetic testing also came back with a factor H variant. This was also of uncertain significance, and the factor H level was normal. So now what do? We have a patient with a TMA, normal level, and it's a VUS. So, like I was mentioning, there are many different ways to handle a VUS, and as Richard mentioned, you could make the variant in vitro, you could conduct analysis, you could do serum-based testing, you could do split product testing. You know, a few years of working in the lab and working with some structural biologists, I've learned a little bit, just enough to be dangerous, but you know, these are a couple people that I work with, and so in a very, very basic level, my understanding was that this was a proline variant, and anything that changes would destabilize the folded protein. But then there are 2 people I often reach out to, David Kavanagh, who is my co-chair at the ClinGen, and he runs the AHAS program at UK. And I asked him, I said, David, have you seen this variant in your cohort before we, you know, there's a lot of time, effort, energy that goes into making these variants, and it's not simple. So the first step is I often reach out to, you know, people, and he said, well, they have one patient, young child with age 7, who they've seen this variant in and it's a C3G, not a TMA. Their C3 and C4 levels are low, everything else is normal, and they actually have a biopsy on their patient where they had 11 gloms, very little fibrosis, some mesangial hypercellularity, and he told me that in view of there being little fibrosis, they have continued MMF, they've stopped her steroids, she's on ARB, she's doing fine. And then, of course, Richard is here, and I want to tell you what he mentioned. I really have to thank you, Richard, and I really want to say this, that anytime I reach out to him, he responds back within minutes and hours. Like, that's how fast the response is. So this was when I reached out to him. He said he has not seen this variant in his cohort, but he gave me this beautiful description. He said it's a proline, highly conserved in position this. There is a similar variant with this pretty picture that he sent me, seen in a similar position, proline to leucine, similar change at 1012. And then the final description was that if you substitute proline with the leucine, it's a significant change because the proline has this unique cyclical structure which imparts rigidity, and leucine makes that pretty flexible. So the idea being that if you make this change, the factor H is not going to fold well, it's not going to attach well, and it's going to be defective. So basically, we are looking at a variant just based on structural analysis that this is a defective variant even though it has normal levels. And so this patient had complement-mediated TMA due to a likely pathogenic, because like we said, we haven't made it, we haven't functionally tested it, but structural analysis alludes to that this is a problematic variant. We call it a type 2 because it has normal levels, but it's possibly functionally defective. And so, you know, between a type 1 and a type 2, where the first patient has a defect in a level, a low level, and versus a patient which has a normal level but has a defective protein, how do you differentiate and how long you would continue therapy? Just some quick thoughts here.
There is a comment from the audience. They really want to stress that there was, since COVID was like recently, a week before delivery, that this definitely could have contributed.
That was my question next. That's great. I'd like to thank that audience person for that. But any thoughts on whether you would change how long you would keep a drug? And I know, Morel, you guys stop it in everybody. But for US, like, do you think that would help differentiate? You would keep a patient, how long you would treat this patient? And it's okay, we really don't know the answers to this, but anything? Carla, I think Carla wants to say something.
Again, I'll go back to recognizing what you said earlier, that the practices are very different in the United States than they are in other countries, but I depend heavily on genetic abnormalities, and if I have a genetic abnormality and I've got a recently injured kidney, I am much more likely to put a patient on and keep them on for an extended period, but I can't tell you exactly how long that extended period is. Historically, I've placed, for instance, a postpartum female on at least 6 months to a year, and then we would negotiate the stop. And then we would discuss again whether, if they're going to get pregnant, whether we would restart. But I think that there are lots of people that don't recur.
Yep.
So we do have to keep that in mind. And I think it's very reasonable with a motivated patient to stop the drug and monitor them in some fashion so that you are prepared, and everybody knows we've got an identified abnormality. We want to be very cognizant to start drug early, if they present with anything that even resembles TMA. Let's not think about TTP again. Let's not think about all the other differential. Let's just go directly to atypical HUS. But I admit freely that I don't have data for that. That's more of a practice and being able to get genetics fairly quickly in my setting. So I can decide those things, fairly quickly.
How often would you do labs in this patient, Carla?
Well, I follow Dr. Ardesino's work from a number of years ago, in that I am still doing urine dipsticks on patients, and whether they're 3 years old or whether they're 28 years old, they're absolutely fine at home doing the dipsticks if they get blood in their urine. Now, this is hopefully if they've gone blood negative, because as you probably know, not everyone does. But if they've gone blood negative, then I would have them doing urine dipsticks at home. If they get 2 in a row that are positive, then I bring them in for a CBC, that sort of thing. We have a protocol that our nurse coordinator actually manages these patients, and she does a beautiful job making sure that nobody gets dropped.
Excellent. And how often are they doing dipsticks at home?
We start them out at 2 to 3 times per week.
Okay.
Then they sort of become creative and do them if they're intercurrent illnesses. They maybe do them a little bit more frequently. Yep. If they're on vacation, maybe they forget to do them, etc. But generally, we start them at 2 to 3 times per week.
Okay. All right, for the sake of time, I think I'm going to skip these, but to the virtual audience, I did have a question whether we thought COVID played a role in case 2 or not, or, yeah.
Oh, I just had one question as far as follow-up. Steve Olson, nephrologist, Novartis. Any use ever of home blood pressure monitoring for recurrence as well, if that was a significant presenting symptom? Because that's obviously something that's easily done at home, and we do it a lot for other patients. Just curious if anyone uses that.
It's not sensitive enough.
Yeah. I mean, they should be monitoring blood pressure anyways, but I don't know if that would. And then I think we have and would you test, the patient did ask whether she wants a 2-month-old child to be tested. Would you test the kid? Yes, no?
I will send it to genetic counselor.
To genetic counselor.
Yeah, my
audience really wants to know about the role of albumin to creatinine ratio here.
The role of albumin to creatinine ratio? You mean, if patients are doing dipsticks you're doing a urine analysis at home? Okay. Anybody wants to answer that question? That if you're, can they elaborate? Are they looking to see if that they see albuminuria, whether they think that's a risk, that's a relapse? Is that what they're referring to?
I think so.
I would bring them in, definitely test them, but I don't know if there is correlation between, you would see hematuria, proteinuria, but Carla, do you have any thoughts on doing albumin creatinine ratio testing specifically just for?
I think, I don't exactly have a comment on that, but I think what I'm hoping with the urine dipsticks for blood is that I'm catching either free hemoglobin or RBCs. So I'm feeling like that I'm getting 2 potential signals that inflammation may be beginning in the kidney again, or that endothelial injury may be beginning again. I think the problem with the urine protein for me would be is that it must be first morning. It has to be predicted to be at exactly the same time. I'm a little bit worried that there may be some variability in the albumin from day to day, et cetera, et cetera. So I'm not sure if I've placed that in my sort of practice at all.
Right, and if you're seeing that in urine dipstick and you bring them in for a formal testing, and if you don't see anything else, I think you would follow or treat it with ACE and ARBs. I'm not sure you'll jump in to do that just with that. All right, I think I'm going to let Anna and Richard take over. So did everybody say no, or just do a genetic counselor, not test the 2-month-old? Yes, Chanavit.
I think it would be important for us to talk to the genetic counselor too, because in the nephrology community, the odd ratio of the disease association for PKD is the highest. For APOL1 is 7 to 9, and we still don't recommend pediatric testing for these conditions. So for an odd ratio much lower in reduced penetrance like this gene, I don't think we should find a case to scare the mom and do not consent the kids to know this until we have more information to know in fact the real penetrance.
All right. We have a short presentation. The panelists have kind of tried to summarize, their approach to pregnancy-associated TMS.
Can you hear? Can you hear? Yeah, okay. So this is a summary, mainly what we were talking, but we put it in some slides. So pregnancy-associated TMA, so we know preeclampsia occur in 3 to 5%, and then the others are rare. HELP is 0.5%, and TTP and atypical HUS is less than 1%. So the rest of the pregnancies, they don't present with TMA, but those are the rates. So here is to mainly understand where they fall in the pregnancy. So preeclampsia and HELP, oh, you cannot see the pointer, and HELP occurred in 23, 24 weeks and above, while TTP, atypical HUS, can present at any time in pregnancy. How do we move this? Okay. And here is some of the information, and mainly in preeclampsia is the most frequent, and all the others are infrequent. Thrombocytopenia you will see in everybody. Hypertension is more in preeclampsia. Renal injury in atypical HUS. Neurological symptoms are more in TTP, and the differential with the Adams TF13, of course, less than 10% will be in TTP, and the others will be 20 to 40% because are the levels in pregnancy. So, and we will go quick with a differential diagnosis. So we have serum creatinine, we order labs, serum creatinine, troponin, blood pressure, proteinuria. If we have a blood pressure more than 140/90, proteinuria more than 0.3, an elevation of ALT, AST, then we think about preeclampsia, eclampsia, and HELP syndrome. If we don't have it, then we will order Adams TF13 and antibody. So if we have an Adams TF13 less than 20% with an antibody present, we are talking about acquired TTP. If we have less than 20% with a negative antibody or inhibitor, we are thinking about congenital TTP. All this is negative. We think about sepsis and postpartum hemorrhage. We order PT, PTT, fibrinogen, and D-dimer to rule out the IC. And then secondary TMAs, we were talking about immune-mediated disorders and antiphospholipid and lupus anticoagulant. Vitamin B12, important to check or to think about, and here I put, don't forget that it's low RT count. And then last, if everything is negative, atypical HUS is an exclusion diagnosis, and then we can order genetic testing, the C3, C4, if you order it, anti-factor H antibodies if needed. I'm going fast because we have 10 minutes. So pregnancy-associated TTP. So pregnancy is the major trigger for TTP in 5 to 10% of the cases, and 1/3 of those cases is going to be congenital TTP. And here we have that there is, during pregnancy, the von Willebrand levels increase significantly, and as you see, I don't have the pointer, but on the right side we have from baseline to the third trimester, how the levels increase significantly. And the Adams TF13 enzyme levels decrease in pregnancy and is usually less than 20% with increase of von Willebrand. Is not a good combination. So always consider TTP in patients with hemolysis and thrombocytopenia before 24 weeks pregnancy. And then complement-mediated TMA also will be triggered by pregnancy, and it occurs in 15 to 20% of the cases, and most of those cases are postpartum. It can happen anytime. So pregnancy is a complement amplifying condition that may trigger atypical HUS.
Thank you. So I'll go through that quick, yeah, and I think understanding pregnancy really can amplify TTC for the reason you mentioned, and also we know it's a complement amplifying condition, so that's why a patient may not have any signs of disease. I think both of those cases, they didn't have any known history of HUS or TMA, but it was sort of the complement activation of pregnancy, and that peaks right at delivery, so we know the fetal exposure to semi-allergenic material is greatest right at delivery, and then so if someone unbeknownst to us, like we see a lot of these complement factor H variants in patients with postpartum atypical HUS. We see a lot of them in patients with HELP syndrome, that if they have variants in factor H, factor I, and those ones tend to be the loss of function where, okay, now you can't regulate the complement system as well, so when it's triggered, you end up getting a higher degree of that C5b9 deposition on the endothelial cells. And well, you guys know as nephrologists that the kidney has a lot of endothelium and is particularly vulnerable to complement deposition, but in pregnancy the placenta is as well. And so a lot of these patients we actually see a lot of C5b9 deposition on the placenta as well. You know, so we talked a lot about that. The workup, the truth is, you know, that hemolysis, thrombocytopenia, kidney injury, that triad is very unique, right? The differential for that combination is very small. Anytime you have those three, atypical HUS should be on your mind. The problem is where you're at in the pregnancy. So I divide that up because if you're under 24 weeks, you're probably going to work up TTP, atypical HUS, lupus nephritis, CAPS, because they're early in pregnancy, so no one's thinking about preeclampsia or HELP syndrome, or they're willing to entertain other diagnoses. And then you reach that box of 24 to 42 weeks, and basically everything's preeclampsia HELP, because now they're in this window where we say that those disorders are can be diagnosed. Those are the trickiest ones, and that's a big area of time, but I think we can do some improvement. TTP, of course, with the ADAM-TS13, I know we've kind of talked about this, but we don't have a gold standard for the complement testing, so that's the hard part, and we definitely don't have anything quick. The genetic testing takes, you know, time to get back. C3, C4 are not going to be definitive, so those are tough ones. But then you go postpartum, that's another group that should be diagnosed and treated. So we talked a lot about once you pass 3 days postpartum, that group should also be getting a broad, extensive workup, but they're not in many cases. And actually these two cases that we presented are idealistic. They were diagnosed and treated. A lot of us in the real world know that that doesn't happen in most cases. Diagnoses are often delayed. One reason is, and these cases were relatively straightforward, but when you look into the literature of postpartum atypical HUS, they're often very sick. Preeclampsia, postpartum hemorrhage, fetal demise, placental abruption. They're in the ICU. So there's a lot going on. And so many providers are hesitant to say, now you think it's a complement-mediated TMA? Doesn't the patient have enough going on already? Can't we just leave them alone and let them get better? But we know that if they do have a TMA, that treatment is going to be very important. We came up with those guidelines to at least serve as a trigger. You know, it's interesting, that second case, I noticed the LDH was like 500, and I agree, actually that may have been a case where kidney biopsy potentially could have been helpful because we don't have a gold standard. We ended up getting the genetic mutation, which was helpful, but if that genetic testing had been negative, people may have debated the etiology of that case. Maybe it was triggered just by COVID, or maybe there was an ATN component. So we talked about, you know, those lab tests. So basically, you know, the way that, if you say take out severe thrombocytopenia, because once someone has a platelet count 30,000, 40,000, they're going to get plasma exchange most of the time if they have hemolysis. So if they have TMA and platelet count under 50,000, TTP is just so life-threatening that, as you guys know, most of them are going to get plasma exchange. But those ones that are above 50,000, that's, you know, going to give you more time. It may give you options such as kidney biopsy. But if your creatinine is over 1.9, LDH over 600 at 3 days postpartum, we found that that was like 95% specific for atypical HUS. And you could probably just treat at that point, you know, even without genetic testing, without a gold standard test, just clinical diagnosis. But if you needed the kidney biopsy, particularly if it's kind of borderline cases and people want to see the tissue diagnosis, some hospitals may not allow you to order eculizumab if you don't have that tissue biopsy. Some countries, that's the case where they require, and we don't want to get to that point where it's required to do a kidney biopsy. We think there's enough clinical suspicion, and then you could do a trial of complement inhibition at that point, see how they respond. Like this case, you responded very well. And if we're talking about 3 to 6 months of treatment, we're not necessarily talking about lifelong in all cases, then, that may make sort of your healthcare team, your hospital system, more open to the idea of treating the patient, and the patient perspective, knowing that they may only need a short course of treatment. So we need a gold standard test. ADAM-TS13 get in that quickly, so I think that's huge because the kidneys, as you know, are potentially being injured, and the recovery is going to be quicker the sooner you can start the complement inhibition. So we just get into rapid ADAM-TS13 more quickly. And we know that if you treat sooner, we don't know where that point is. Is it 3 days, 4 days, 1 week, 2 weeks? But we know that if you don't treat with complement inhibition, you're going to have a higher risk of end-stage renal disease, dialysis, transplant, and mortality. And you could decrease that dramatically with starting complement blockade. So ideally it's sooner, but at least if it's, like in that case where it was 1 week out, you could argue maybe, or case one where it was 1 week out, maybe you could have started treatment, 2 or 3 days earlier. But still, in most cases, as long as you get the treatment, you're going to have better long-term recovery. So we can answer questions. I know in the interest of time, there's a lot of discussion that can go into other agents like the ravulizumab, rituximab, that we haven't talked about. But for pregnancy, we're still for complement-mediated TMA, eculizumab. We don't have safety data. Ravulizumab, it has much higher binding to the neonatal FC receptor, so it crosses the placenta readily. We presume it gets into breast milk. So right now, for pregnancy and postpartum with those who are breastfeeding, we prefer eculizumab, and hopefully eventually maybe we gain some additional data on Ravu.
That's it.
So, perfect.
All
We'll have
right.
a thank you slide. So, our thank you slide at the end after that. We'll go skip to the end. Thank
Okay.
you.
Thank
you,
you.
everybody. Appreciate your time and your